I had a very interesting case. I was doing a tummy tuck to improve the abdominal wall contour of a patient who had had multiple prior medically necessary abdominal wall surgeries. One was for an intra-abdominal abscess, another was for a ventral hernia. So the contour of her abdominal wall was not smooth and showed through her clothes, and parts of it were causing her some pain. So we decided to try to improve her contour. It was considered a cosmetic case because it was to improve the appearance of the area. It may help with her pain, but there was no guarantee of that. She had a lot of scar tissue, and I thought that releasing some of that scar tissue would probably help her pain. A lot of times people ask me about the training of plastic surgeons and why our training is so extensive. Why do we rotate through general surgery first? Why do we have experience on all the other surgical specialties? And it's because when we're restoring tissues in the body, we often encounter bony problems that have to be fixed, vascular problems that have to be fixed, nerve problems that have to be fixed, especially in trauma. And when we're operating around the abdomen or breast area, other general surgical considerations. I was trained in general surgery first, and then did a plastic surgery fellowship or residency, and then an additional fellowship in microsurgery, which is operating under the microscope. All of his training comes in handy in every single case. So why we're so, it was so important to inform patients about credentialing for doing these types of surgeries is many people with out appropriate training who are not board certified and that their safety profiles are not examined by our board are able to do operations. But if everything's routine and there's no complication, that's fine. But we never know what we're going to encounter in a situation. And in this case, I was operating and all the anatomy appeared normal until it didn't. There was a very unusual bit of tissue on the right side of the abdomen. It tunneled up all the way from her hip bone up to under her breast on the right side. And it was a very complicated problem to fix. I had to excise all of these tissues. It was probably a seroma cavity from some fluid in there from her prior operations. But if I did not address that issue, take out all that tissue, it probably would have recurred. She would have been at a higher risk for infection. It probably would have had to been drained. So the important thing is that no matter what we're doing, that we are prepared to handle anything that comes up. That comes with experience and excellent training. Also, there's something called informed consent, that on all my cases that I think are going to be very complicated or complex, I always add other procedures as indicated because I have enough experience now to know that I can encounter anything and that should be addressed at the time of the surgery instead of subjecting the patient to a secondary surgery if that can be avoided. So our case was very successful. We eliminated a problem that even if she hadn't had a tummy tuck, probably could have affected her later on in her life. It was tethering. It was not normal anatomy, and it was causing her a lot of pain. And so releasing all that scar tissue and excising what was a prior large seroma cavity should help her overall contour and, more importantly, her comfort, and very importantly, her safety in the future from having an abdominal wall complication from her prior medical history.